Great, thank you. So thanks for the opportunity to speak today. So I'll be speaking first, followed by Bridget, and then Scott. I'd also like to acknowledge that I'm joining remotely from Noongar Whadjuk Budja, and the artwork you can see here on the screen is by Leilani Tallulah Knight, a Wiradjuri and Kamilaroi queer artist whose work aims to integrate the traditional works of her family with her own abstract style while facilitating conversations around culture, time, and place. So the piece is entitled You're Gonna Listen Now and was commissioned by our Faculty of Arts, Design and Architecture. So I'll be presenting the first part on this pilot research collaboration undertaken between UNSW, the University of Sydney, ACON and the Cancer Institute New South Wales, which culminated in a journal article published in Research Ethics and a report. And I'll put links to these in the chat after my presentation. And I just want to thank all the stakeholders who took part in our interviews, which Bridget will be discussing next. So I want to start by talking about what we know. We know that there are higher rates of some cancer-related risk behaviours and rates of some types of cancer among LGBTQ+ populations. And we know that for some cancers, there's less frequent cancer screening among LGBTQ+ populations. And this is partly because LGBTQ+ communities may be reluctant to engage with mainstream health services due to stigma, discrimination, and past trauma. Recent research led by Usher et al. Show that while there are some positive experiences with inclusive and reflective practitioners amongst LGBTIQ+ cancer survivors, there are also significant barriers to culturally safe care and higher experiences of distress compared to the general population of people diagnosed with cancer. While there's a lot of research happening on direct experiences of cancer care and survivorship, we know a lot less about LGBTQ+ participation in cancer clinical trials. And trials are important for developing new knowledge about what therapies work and why. And it's important that trial participants are diverse and reflect the real world population who will be engaging in those treatments. So what do we know about LGBTQ+ participation in cancer clinical trials? The short answer is not enough, and primarily the research is from the United States. There's one cohort study of US residents' health-related risks. So it's a cohort of people just looking at broad health risks. And interestingly, they've published two series of papers 10 years apart, where they found that more people in their cohort who were sexual and gender minorities, that's the language they use, were more likely, found that they were more likely to report enrollment in cancer clinical trials than their cisgender heterosexual peers in the cohort. They don't know why that is, and those studies are less helpful in telling us about the representativeness of trials for LGBTQ+ people, but the papers are quite interesting in that they do a good job of reporting some key barriers that LGBTQ+ people may experience regarding trial participation. Contemporary research suggests that there's a wholesale lack of reporting of sexual and gender minorities in cancer clinical trials, especially those listed on clinicaltrials.gov. And other published literature indicates a range of barriers for LGBTQ+ people, including issues with trial eligibility or reporting that conflates sex and gender or conflates sex and gender with anatomy, exclusion of people who are on hormone therapy or people living with HIV, or exclusionary eligibility language. While there is published literature in the United States on this topic, there's very little published on this topic in Australia and no real understanding of the diversity of cohorts within cancer clinical trials in Australia, at least in the published literature. One exception to this is a recent study, which I should note was published shortly after we completed and published our research that we're talking about today. This study examined patient diversity within early phase clinical trials in Sydney across a range of types of cancers. So these were people enrolled across some different hospitals in the Sydney region. And the participants were enrolled between August 2023 and August 2024. Now, interestingly, so they published this paper looking at the diversity of participants in their cohort, and they found that there was some pretty good cultural and linguistic diversity. So 30% of people identified as culturally diverse and 25% as linguistically diverse. And they had an even gender split, but no non-binary participants, and they only asked a single self-reported gender question. So you can see they reported 52% female, 48% male. They also reported that all participants were heterosexual with no LGBTQIA plus participants. And I wouldn't normally frame heterosexual versus LGBTQIA plus, given it's confusing, gender with innate variations of sex characteristics, but that's actually the way they reported it, which is maybe not the best way to frame sexuality. And they just had a self-reported sexuality question. So you can see here that there's a lot of work to be done. So achieving LGBTQ plus health equity is a priority area for action to improve health outcomes. And we're seeing a lot of people point out that accuracy of data collection is a key issue affecting understandings of outcomes. We know that recommendations for the collection, analysis, and reporting of sex and gender variables in Australian health and medical research is highly inconsistent. But there is a growing emphasis from government and other organizations to improve standards of data collection. So, we've seen since 2020 the ABS standard for sex, gender, variations of sex characteristics, and sex orientation variables. We now have the National Action Plan for the health and well-being of LGBTIQA plus people. And from 2026, all National Health and Medical Research Council grant applications will require applicants to explain how they are addressing those variables in the ABS standard. So that's hopefully going to promote more researchers to be collecting these variables more consistently. But we know very little about how the ABS standard is actually being implemented in practice, including in relation to LGBTQ plus populations and cancer clinical trials. And there are many questions that come up beyond just data collection. You know, so are LGBTQ plus people being recorded in trial settings? What data is being collected, if at all? What are the perspectives of the cancer clinical trial workforce on these issues? How is eligibility framed in the context of language around sex and gender or use of hormone replacement therapy? How are things like safe sex discussed? Is it inclusive? So they might be discussing safe sex because of the consequence of cytotoxic agents when someone's on cancer therapies. So there's a lot of potential questions here that intersect with LGBTQ plus people. So this was a pilot study, and it was a collaboration with two key aims. Firstly, to develop a clear understanding of the state of LGBTQ plus data collection in cancer clinical trials in New South Wales, and to develop recommendations for practicable actions to support healthcare workers and researchers to improve inclusive data collection. We received ethics approval from the UNSW Human Research Ethics and ACON work. And our pilot study involved two key methods: a scoping review to map what is known about the collection of gender and sexuality data in cancer clinical trials, and key informant interviews with professionals regarding barriers and facilitators to collecting this data, which Bridget will speak to next. I also want to mention that while we consider these topics to be highly relevant to people with innate variations of sex characteristics or intersex, it was unfortunately beyond the scope of this study to focus on these populations specifically. This was a relatively small pilot study, and we decided that we would not be able to do justice to the specific needs of people with innate variations of sex characteristics. And so by trying to clumsily include them, we would potentially be risking collapsing I into the broader LGBTQ. So there's a lot more work to be done in this space. So I'm going to talk about the scoping review before handing over to Bridget for the interviews. And I want to particularly acknowledge the work of Karen Drysdale, who led the scoping review component. For those who are unfamiliar, a scoping review provides a transparent, rigorous, and structured process for mapping literature in order to explore the breadth of existing research and identify knowledge and research gaps. And this is especially a good review methodology when there's limited published research on the topic. The research question we came to the scoping review with was, what is known about the collection of gender and sexuality data in cancer clinical trials, current practices and perceptions among healthcare professionals regarding barriers and facilitators to collecting this data? And we looked at peer-reviewed literature published over a 5-year period. So you can see on the table in the top right that we used a number of different databases, cross-checked it with other searches, a variety of search terms to encompass the complexity of our communities, particular search terms related to cancer, trials, and different aspects of data collection. In the bottom right figure, you can see that through this search process and screening the articles, we found a total of 3 articles through the databases, supplemented that with another 3 through hand searching their reference lists and checking Google Scholar, and found only 6 articles in the end that really fell into all of this criteria. So the scoping review yielded 6 articles in total, which included studies involving national assessments and audits of cancer clinical trials, a literature review, and surveys with healthcare professionals and with segments of LGBTQ plus populations. Most of the studies were from the United States, 2 were from the UK, and they focus on a few different topics, including data collection practices, perceptions of data collection, how data is annotated in biobank records, and some of the implications to improve data collection. More importantly, what did this literature tell us? Firstly, there's a dearth of research overall and no Australian research in the scoping review period. We found that routine or reported gender and sexuality data collection was low in these studies. And we also found that studies drew on varied definitions of gender and sexuality. In some studies, they collapsed LGBT into one category in reporting without sort of pulling apart the meaningful differences. There was also a lack of clarity around the sex and gender terminology that was used to kind of categorize people. And there was only one study that used a 2-step approach of asking gender identity and sex assigned at birth. That would sort of align with what we do in Australia with the ABS. More usefully, the review, the literature reveals some important insights into barriers and facilitators to data collection. Barriers include systemic issues regarding how sex, gender, and sexual orientation data are collected in forms and electronic health records. Healthcare professionals' experiences and perceptions are both a potential barrier and facilitator. So if healthcare professionals have better LGBTQ plus competency and understand the importance of collecting this data, then they're more likely to feel confident asking about it in clinical consultations or more likely to advocate for collecting it within their system. And there were also a number of community-based solutions for trying to improve the representation of LGBTQ plus people in trials, which includes improving community trust in health services and trials, co-designing and co-delivering services, and other forms of community engagement. And with that, I'm going to pass on to Bridget to discuss the interviews, which tell us a lot more about what is happening locally. Thanks.
Thanks so much, Anthony. I'll just share my screen. Sorry, it's just taken me a moment. Okay, thank you. So I'm just acknowledging that I am on Gadigal land, and you can see the names of the people on the research team below here on this interview, on this slide. This is another slide here, which is actually from Barkindji land. And to me, it's a picture of the dawn, symbolising that, we are in a new dawn of trying to change the way that the collection of these indicators go. As Anthony has already told you very effectively, that there are not, there's very little data on LGBTQ people in cancer trials. It's because it's not collected. And in many cases, it's not collected because people have thought that it doesn't matter. I'll elaborate on that a little bit further as we go along. So we developed an interview guide, which was based on the literature review that Karen Drysdale did, and also in consultation with the research team, including ACON and the Cancer Institute. Our interviews involved asking questions about participants' professional backgrounds and their perspectives on inclusions. And they were recruited using advertisements from, particularly from the Psycho-Oncology Cooperative Research Group and other Australian and New Zealand Zealand Cancer Cooperative Clinical Trial Groups and the professional networks of the investigators here. We conducted 11 interviews in all, but we only had 10 eligible participants. So one of the people in our interviews was involved in cancer care, but not actually involved in cancer clinical trials. And that became clear. And so they're excluded from this analysis. It included professionals who were working in some capacity in frontline care, such as trial coordination, directing the clinical services. And we had both generalist oncology care people represented and people who came from specialties like radiation, gastroenterology, hepatology, and genitourinary cancers. Overall, 5 cisgender men, 4 cisgender women, 1 person was non-binary. They all worked in publicly funded clinics, 7 urban and 3 regional. So it's a small group of people that we did interviews with. But within that small group, we actually had quite a deal of diversity in terms of people's knowledge and experience, as I'll explain to you. So Anthony and I conducted each of the interviews and we wrote field notes immediately after each interview. They were audio recorded. Hariana, another member of our team, transcribed them, checked for accuracy. Then 2 members of the team independently coded. 4 transcripts met together to discuss the coding and the emerging analysis, and then that was applied. So Anthony led the data analysis in collaboration with me and the research team and with ACON and the Cancer Council. We focused our analysis on barriers and facilitators very much because that was the brief here. So number 1, lack of training. Very few of our interviewees had training on LGBTQ plus, TQI plus issues, and there was a huge difference depending on whether or not people had training. And people who had training, so those who had actually had, and it was usually a kind of ACON-based training that they'd done, those who had that training were very acutely aware of the issues and were huge advocates for how transformative the potential of training could be, because I think in particular they were able to reflect on how it had impacted their understanding and their practice. The other thing, in addition to training, that made a big difference was whether or not the people who were interviewed had lived experience in some way of LGBTQ plus communities, particularly whether they identified or whether they had close family members who did. That seemed to really open people's minds, and it seemed to change the kind of the understanding of what the issues were. Making assumptions was an enormous barrier to effectively collecting data on LGBTQI plus indicators. People basically said, many of the people, particularly those who had not had training and didn't actually have that lived experience connection, would just say, well, we don't need to do this. Everything we're doing is already fine. We are already, giving we deliver patient-focused care. We take a great deal of, we take social histories. We know everything that we need to know. Where would we do it anyway? Use of language was also a barrier. So people weren't clear about what language to use, and some of the language that they used was very exclusionary. And I'm going to give you some examples of this. So here is a quote that speaks to both the training issue, assumptions, and language. This person, P10, says, I don't think there's anyone who said, I'm not coming into a trial, or their partner or family says something like, you're not being treated appropriately because of your sexual affiliation or gender or whatever. So I don't think we can do better. I think we do well. This really is quite emblematic of a particular perspective in this group. So it wasn't just one person, P10, who was giving us that. We can't do better than we're already doing. We're already doing everything we need to. And within that, already using really odd language like sexual affiliation and so forth. I should point out at this point that I am using, the kind of rainbow acronym here. It was quite clear to me doing these interviews that the rainbow acronym is in itself sometimes really problematic. particularly because of the way that it lumps lesbian, gay, bisexual, and other queer experience together with trans people. And as became very clear in the interviews, people who were involved in clinical trials were actively quite nervous about how trans people fitted into their world. And they, when you talk to them about it, they were really, they were able to see, you know, big problems in the way that their systems were not adequately accommodating trans people, and they didn't know how to collect the data sensitively or to record it and have that going into the record. Here's another sample quote about barriers, assumptions. I'll just read out part of it. So P11, who is much more aware of the issues that we were talking about, was saying, we're dealing with a lot of cancers that are traditionally identified as male cancers. I think we're going to inadvertently exclude trans females, so he's using that term, who are not getting care and being inadvertently excluded both from normal clinical practice as well as access to clinical trials because they identify differently to what we would expect for someone with prostate cancer and testicular cancer. These kinds of issues came up again and again, also discussed in relation to trans men and non-binary people accessing any form of breast cancer care. As we know, breast cancer is this kind of weird, heteronormative, infantilizing pink space, which is very not inclusive and not recognizing how people with breast cancer come in all different genders. Another quote here about barriers, which is about language and systemic assumptions. A lot of people from the trans community specifically find the very stringent requirements of clinical trial pregnancy testing to be quite confronting at times. So people who are assigned female at birth during clinical trials are required to have pregnancy testing regularly. And so this is something that I wasn't aware of when I went into this research. So if you're a trans man or a non-binary person in a study, because you were assigned or reported female at birth, you're going to be required to constantly undergo this pregnancy testing, which can be quite confronting to people. P4 was another very knowledgeable participant of ours and was thinking quite analytically about the categories of male and female and how problematic that they can be. And they say, I think that also, I guess, there's still to some extent there remains a complex relationship between the healthcare system generally for some people within these communities, and that bleeds into cancer care as well, and also cancer clinical trials. So the facilitators that were identified in our interviews were the use of inclusive signs and symbols. I know all of us who work in this area can get a little bit jaded about kind of, you know, rainbow washing, waving flags and so on. However, when people are in spaces that can feel quite alien, there is now quite a lot of research, and our research reiterates that. Also, research that I've personally done with very vulnerable trans women in a different study, talked about how those inclusive signs and symbols really make a difference to them. So this was an important thing. The people who had done training were very clear that having inclusive signs and symbols was important, but also that it needed to be underpinned by something real. It couldn't just be an image if that image didn't relate to a person actually knowing to ask somebody about their pronouns or having some kind of understanding of the particular issues that might be being experienced by somebody who fitted somehow into a gender or sexuality minority, then that would not be useful. So inclusive signs and symbols, so long as it's backed by things like workforce training. Building trust was spoken about as being extremely important in terms of getting the capacity to ask the questions. So remember that this study was focused on trying to find out how we can actually get people in clinical trial settings to record data about people's LGBTQ status. So building trust to make that possible. And then the final question is very much a pragmatic question about feasibility. When do you collect it? Where is the point that you should actually do that? And there was a lot of discussion about points where that would naturally come up. Interestingly, one of our interview participants was very gung-ho about just wanting to ask everybody and saying, I don't care if I put off a few people in this. It's really important. It doesn't matter to me if I've, made a couple of, redneck conservatives feel alarmed. So much better to do that, but to ensure that any of the LGBTQ people who come here are made to feel comfortable is so much more important. So that was an interesting point to come across in one of the study participants. So here is a quote from P4. I think that creating comforting, warm spaces for people include a celebration of LGBTQ plus slogans or logos. It's really important in the same way that we increasingly celebrate First Nations people. And I think that was a lovely perspective, and was very deeply thought there by P4 about how we really need to be including these signs and symbols. In terms of building trust, P6 said you have to make people feel supported. They need to feel comfortable to share information with you. And P6 had previously talked about an instance where a patient in a clinical trial had initially been presenting herself as being there with her friend. And P6 goes on to say, so like I mentioned, the rapport really kicked off once we broke through the ice with her saying something like, that's my partner, not my friend. So P6 here is talking about that moment where the trial participant stops putting up barriers because she's feeling a level of trust here with the clinical trialist, and is able to actually communicate that that's her partner. Of course, what we are trying to do is to ensure that people are collecting that data a little bit earlier on in the process. So that trust needs to be built earlier on in the process. When and where to ask. P8 says in the waiting room while they're filling out forms. We ask your age, your date of birth, where do you live, male or female, are you Aboriginal background or not, do you identify as? That's probably where we should be having a question of this element. It shouldn't be well into the interview, well into the process to say, oh, hold on, how do you want to be managed? So this was, I think, pretty much where we landed, that the idea is that it should be a standard indicator that is put there on a form. I would advocate for having the two-step gender process and then asking about sexuality separately, so not lumping LGBTQ plus together as a kind of monolith, because I think that that's not particularly helpful. So actually having a kind of a more structured along the lines of the ABS standard process, I think would be better. So we came up with a number of recommendations. So for LGBT plus, GQ plus community-based organisations is to develop and maintain a list of inclusive resources to provide to cancer clinical trial teams. With the support of government organisation, to write to the human ethics chairs at local health districts and universities to promote the ABS standard and other LGBTQ plus inclusive resources. So at the university where Anthony and I work, the ABS standard is standard and needs to be included in all of our research projects. And if researchers don't do it, they're asked why. But that's unusual. I don't believe that that is the case. It's not in the national statement that all human research ethics committees have to apply at this stage. So it is important work there. In terms of recommendation for governance and ethics bodies, The first recommendation is to advocate to national research bodies to promote sex and gender data collection standards, to ethics committees, and to incorporate into health and medical research guidelines. So that has been happening a lot. Anthony mentioned the NHMRC, which is National Health and Medical Research Council, is already writing this into to research grants. So researchers are needing to do it, but we don't have it currently in the national statement on human research, and it needs to be in there as well. The recommendation goes on to say the guidelines should address using anatomical language for inclusion and exclusion criteria to avoid gender normative assumptions regarding anatomy. So instead of saying men, you'd say people with a prostate, using that inclusive anatomical language. Advocating for minimum data sets across government institutions that includes standard sex and gender questions. And again, currently the ABS standard is the best that we have. That's being refined with the census questions now. And obviously things are not going to remain set in stone forever, but having a kind of a minimum standard would be an important step forward. In terms of the clinical trial sector, actually having some co-designed guidelines for LGBTQ plus inclusivity in cancer clinical trials is a really important one. And work has been done here by Jane Usher and her group on how to do this in cancer care. I'm not sure that is applying specifically to cancer clinical trials at the moment, but it's probably not too much work to adapt the fantastic resources that research group has come up with. So this needs to include sex and gender questions, sexuality questions, recording pronouns, preferred names, discussing hormone replacement therapy, trial eligibility, and how to approach conversations about fertility and pregnancy. So this came up in our interviews, particularly from one of the participants who was well trained, that they were saying that they thought that many of their colleagues wouldn't recognise, for example, that people who are sexuality or gender diverse may still be wanting to have children because of that kind of quite outdated norm or stereotype about us as being childless. So co-design should take place with researchers, cancer clinical trial specialists, sponsors, investigators and coordinators, and community-based organisations to make sure it's fit for purpose. And the next point there on the slide is about developing co-design training packages in cancer clinical trials. My partner was on a cancer clinical trial in 2003, and there was absolutely nothing made available to her or to us as a family around sexuality, or recognising that sexuality might have made her experience of being in a cancer clinical trial at all different. General action items to promote the use of standard data collection, such as the ABS standard, in your own clinical trial. So that's something that researchers can do now. It's something that we can do in our universities and institutions as well, in terms of requiring, for example, ethics committees to use these to ensure that the data is collected, and in our editorial, peer review and other research-based roles, that we can also set standards there. For example, Anthony and I are on the editorial team for research ethics, where we do ask that people are recording LGBTQ A+ status. And reflect on how to ensure that your writing and research practices are LGBTQ+ inclusive, so being careful about language and framing and not using gender normative assumptions about anatomy. So thank you for your time, and I would like to echo Anthony in thanking all of the participants who generously shared their time and their insights in this study. Thank you.
Thank you, Bridget and Anthony, for setting the scene. I will finish off by sharing what ACON has been working on in order to implement some of these recommendations. So I've titled this From Principles to Practice, Strengthening LGBTQ Inclusion in Cancer Clinical Trials, and I'll I'll highlight particularly the recommendations from those from what LGBTQ plus organizations can be doing in this space to include more, include our communities better in clinical trials. I too would like to acknowledge the traditional owners of the lands on which we're coming to you. I'm joining from Gadigal land at ACON's office, and this artwork comes from our wrap and is an interpretation of the rainbow serpent for our wrap at ACON. This, what I'll present today sits within our Can We brand and our Can We digital platform. So I will show you some of the tools that we have made available, but all of this is publicly available through the website. And this is part of broader work that we've been doing over the last decade and a range of campaign and community focused elements, as well as training and other pieces of research. And what we found here in this research in cancer clinical trials is consistent with what we see across many different areas of our work in cancer programs. Particularly a parallel project to this on bowel screening made very similar recommendations. So there's a broad need for this, not just in trials, but in the cancer sector more broadly. So as I said, this will cover off these two recommendations, mainly focused on 1.A to develop a list of existing materials, but also we have been working with Cancer Institute on 1B as well to write to chairs of human ethics committees. So why this makes a difference? We've covered some of that already, but inclusive data what makes a more inclusive service is inclusive data collection, inclusive information and communication, reflective and affirming clinical practice, and visible symbols in inclusive environments. So to help with this, the Cancer Institute, ACON from the cancer programs team, and the our Pride in Health and Wellbeing and our Pride training teams worked on developing this inclusion toolkit, which is available on the Can We website. The URL is there, but I'll go through some of the key elements of this quickly now for you. So we know that inclusive data collection is important. The use of names, pronouns, asking gender, sex characteristics, and sexual orientation respectfully, avoiding forcing people into inaccurate boxes, and explain why the information is collected. And so in the toolkit to help with that, we have examples of client registration forms, guides on asking questions about gender and sexuality, and ACON's recommended community indicators. So for inclusive information and communication, it's important to have inclusive language, avoid assumptions about anatomy, gender, and partners, and ensure images reflect our communities and our ourselves, and to try to use peer-led and community-informed approaches where possible. So again, in the toolkit, we have some of the resources from here, featuring some of the resources from TransHub about a trans-affirming language guide and 10 tips clinicians working with trans and gender diverse people. We also have on our website ACON GP letters for cervical screening on the Can We website, but TransHub also has versions of these, which can help patients, but also it can help clinicians with the consent of their patients to share information in a written form rather than having to retell their story over and over at appointments. For practical tips for clinician practice and workforce capability, training does build confidence and reduces harm, and I'll show you some results of that in a moment. What we're trying to encourage is reflective practice, and again, coming back to the Out With Cancer research that Jane Usher's team led, is that reflective practice in affirming is the ideal of what we want clinicians, how we want clinicians to practice and engage with our communities. It's important that people recognize that they may make mistakes and to correct them simply and respectfully, and also to take a trauma-informed and person-centered approach to caring for our communities. In the Toolkit, we have a section on inclusion training. There is training available through EvaQ that was developed through ACON and our Pride training program. And this is freely available for people working in cancer services. But our Pride training program also offers both off-the-shelf training options as well as bespoke training options that can be customized for needs of particular organizations. And here, this slide just shows that from that work that we've done with Cancer Institute and EvaQ, that training does shift both knowledge and knowledge of our communities, but it also helps to shift behavior change within practice so that people are implementing small things within their practice that can actually make a difference that they picked up through the training. Finally, symbols and inclusive environments. Bridget mentioned this, that they can be quite important to give signals to people from our communities that there is a sense of safety and that there are considerations for how to include our communities. That can be little signs such as rainbow symbols, forms, posters, and waiting room that signal inclusion, clear processes for people to share their names and their pronouns, and consistency is important. And I think that's where that training really helps back this up. So it's more than just decoration. And again, the toolkit has links to places where you can get some of these symbols, pronoun badges that staff can wear, or inclusive pride flags. So I guess just to simplify, some quick takeaways that services can do to implement these is to start with one small change. That may be changing forms, signage, or reviewing your communication. You can build relationships with local LGBTQ+ organizations like ACON to help design and implement changes, and to use the toolkit to review your service and plan improvements. And for those that want to go a little bit further, our Pride and Health and Wellbeing program offers a membership program that can reflect on the policies and practices of services and also help provide support for implementing changes in those services. And with that, I'd like to thank you and happy to open it up for questions.
Scott and Anthony and Bridget, thank you very much for that incredible series of presentations. I thought it was incredibly well put together in terms of establishing the issue, doing research, and then you Scott, coming in with almost solutions that were really practical and mindful, incredibly well thought through process, and that must have been a wonderful project to be a part of. As you said, Scott, it's open for questions. Do we have any from anybody on the call? I can't see any particularly in the chat as such, but is there any burning questions people have out there? Melissa, would you like to tell us your question?
I'm not sure if the right microphone's working because I had my headset off, but just jumping in if nobody else has questions, because I can jump into that paper and have a read as well. But I was curious, I'm doing research, it's not clinical trials, but more behavioral research, and we haven't been asking, so we would generally ask people about their gender just as a demographic question and try and make sure that they're aligned with ACON's recommendations, but haven't been asking other questions. And I was curious from those of you researching in this space if you think it is, because I guess the thing with demographic questions is not asking people the questions that aren't relevant or appropriate, but maybe it is useful to be perhaps capturing some additional questions around sex or sexuality to see if people are being included in the research or excluded in the research. I was curious on your thoughts, but I'm also happy to dive into the paper that's provided and other things as well.
Yeah, I'm happy to take that. I mean, I think the ABS standard or the ACON indicators are quite similar. There's just some slight tweaking in the wording. I think are a really good starting place in terms of the kind of basic indicators that should be asked in general population research. There is some argument that, if you're doing a much more specific LGBTQ focused research or trans focused research, that the range of questions you're going to ask might look a bit different. And there are some different ways of structuring those questions. I think we're seeing an increase in, especially in trans-specific research, moving away from the describe your gender identity and then sex assigned at birth to instead asking about a wider range of gender options, asking if the person identifies as trans or gender diverse, and maybe avoiding the sex assigned at birth at framing, which there are some critiques of. But for a general population study where you're trying to ask everyone, the two-step ABS approach is considered the best, because we know that if you ask people directly if they're trans, or if you're using very particular terminology specific to the LGBTQ community, that can be very off-putting to people who are a bit older, or maybe English is their second language. So, a lot of people don't know what cisgender means, so you can't really ask people if they identify as a cisgender man, because it just doesn't make sense as a category for most people. So yeah, it's quite a complicated space. But I can see Bridget has her hand up, so.
Sorry, I'm working on a weirdly broken computer, which is why half my screen is dark. I think it's a great idea to be asking people about their sexuality as well, because otherwise the presumption just tends to be that everybody's straight. And also it can bring you nice surprises. So your sample might be much more diverse than you think, or less diverse than you think. And sometimes if you end up with a sample and think, well, actually every single person in my sample was heterosexual, actually that's probably a problem. So I think it illuminates things. And I probably would have said something different 10 years ago. I would have not seen it. I feel like I've become a bit of a convert to collecting these data. I think that they do make a difference.
Yeah, that's really helpful. Thank you both, Anthony and Bridget, because I think that's the question: what's intrusive and unnecessary, or what is it actually helpful to know in a general population cancer survey, people's sexuality, to see if you are actually capturing everybody or not? Cool. Thank you. That's so helpful.
Sarah, you've got your hand up. I have a question, and then we'll go to there's a couple of questions in the chat as well. I think you're on mute, Sarah.
Sorry about that. I had that right all the way up. So I'm Sarah Gerritsen from the Cancer Institute in our Behavioural Research and Evidence team. And I was just going to add on the same topic, because it's such a good question, Melissa, and one that we've struggled with at the Cancer Institute, particularly in our population level surveys, is how much is too much information to collect from people. We definitely do the two-step gender questions, so gender and sex assigned at birth, but the sexuality one is one we've had big discussions with, and I think for cancer care research and clinical trials, it's really important for all those reasons you outlined, Bridget. But I think you also have to have a research question that's really specific to it if you are asking, because we did have kickback from an ethics committee about it, including it in a tobacco survey. So I think there's legitimate reasons for collecting sexuality, but you just have to be really clear why you are, particularly if it's not face-to-face data collection. I think qualitative research, it could be more set up and appropriate, but yeah, in those quantitative big government surveys, it could be seen as a bit intrusive. So yeah, really keen to get more thoughts on that, because Anthony and Bridget, this really great presentations, and Scott, love your work, of course. And yeah, I know you guys have got more to say on this, so I'll hand back, but thank you.
Scott, you're up next. Yep.
Yeah, thanks, Brent. I was just going to respond to that. I think my position is that it's really important that we're collecting both that gender and sexuality questions. I think to normalize asking questions about sexuality for the whole population is important. But I also think in the example that you've given around smoking and tobacco use, we know that there are big variations within smoking rates within gay men, lesbian women, and bisexual men and women. We have very little of that data here in Australia. So that really comes from insights from American data. But there are real differences between that. And if we don't ask those questions, we're not going to see those. We can't plan our interventions and we can't measure whether we're making progress.
Bridget, you've also got your hand up.
Yeah, I love that example that you gave, Sarah, because I think it's a beautiful example of ethics committees getting things wrong. And I think it really points to one of the points that we had on our slide about the need to educate them. And I feel like our ethics committee has really changed that. If I could give you an example in cancer care of where this stuff matters. So my partner died of cancer in 2023. She was on a clinical trial before then. I've been through every waiting room. I have absolutely been in that space. The one time that was it was actually, luckily we had senses of humor, was when she was about to get her first chemotherapy, was when the nurse came in and was giving you all the things about what you do when you're taking cytotoxic drugs. And she says, and if you have the sex, you must use the condom. Now, we both pissed ourselves laughing. And she thought, I don't know what, I mean, she clearly, other people, like the clinicians, because there's these hierarchies. So some people would have known that I was Marianne's partner, but in this context, because there's nothing written down, I'm just, the nice friend. And then she looked at us and said, "Oh, you may laugh, but I've seen what happens on the dexamethasone," which is a steroid that people who are having chemotherapy take, which just made us laugh more and more because people do get hyper on dexamethasone. But the idea of then all of these rushing kind of people in the chemotherapy ward running around because they couldn't control themselves and looking for condoms everywhere, it made us laugh. Other people mightn't laugh when you get such tone deaf kind of sexuality blind treatment in a place that's meant to be treating you as a human being. So, it really does matter.
Thank you, both Scott and Bridget, but Bridget especially for a really important point, I think, and really meaningful. There's a question here from Daniel. Daniel, you're asking, do you think sexuality and gender questions in this year's census alongside the long-term health condition questions, which includes cancer, will provide us with more insight around disproportionate cancer burden with our communities and experience? Would one of you like to talk to that?
I'm just going to quickly poke my head in here and say, we know about our communities and smoking, particularly I guess for me, growing up as a queer person, all of our venues were smoke-filled venues. Being a non-smoker was weird. And we know about our communities and alcohol. I mean, thank God for online dating. I think that's possibly made a big difference to queer alcohol consumption. But that's, most of us have matured in cultures where we are probably more exposed to carcinogens than other people. There's a relationship to the way that we have socialized, because that was how we could. And those differences, I think, really do matter. So I can't remember what the start of this question was now. I'm trying to scroll back to see what the question was.
It was around sexuality and gender questions in this year's census.
So I think that there are
conditions.
I think that there are these behavioural things that sit there, as well as things around the access to care, because we also know, obviously, that there's lots and lots of access to care things, and it's still not even dead, ideas that lesbians don't need cervical screening. You would think it would be dead by now, but it's not completely. There is so much that actually increases our risks. Yeah, and and we need the data to be able to show this, because without that, we don't have an argument.
Thank
Yes.
you. Oh, sorry.
Brent, I was just going to add to that. The census data will allow data linkage, which I think will be really important. It's not going to help with our point of care service, and that's why it's really important that this data is collected on intake forms and stuff. But what we will be able to do with census data and our communities being asked about or being recorded in the census is that it can be linked with lots of different data sets, which then help inform what's happening at a population level. So that's going to be really transformational, particularly for cancer care, where we don't have gender and sexuality in cancer registries or screening registries and stuff.
Thanks. I don't think we've actually hit 3 o'clock, and so we don't actually have time now. Tidja, I am so sorry for your question, but I will get our panelists to consider it and write perhaps a quick response to the question. But our time is really up. Can I just say thank you so much for a really brilliant presentation from the three of you. A really well thought through, meaningful piece of work, and so important for our communities as well. And from all of us here on the call, thank you. If you look out for emails for more research forums, there'll be more as the year goes on. There always are. I look out for more. But thank you everybody for coming along this afternoon. And I hope you enjoy the rest of your afternoon. Thank you.